This video is not only about managing an infected and an injured eye, but also a message to the public at large. This individual presented to us after a penetrating injury with a flying object, and this was presented after 4 days of injury. And this is the procedure in which we had planned the repair of the corneal perforation and reposition of the iris prolapse, along with anterior chamber lavage and flushing the contents and intravitreal antibiotic injection to combat the ongoing infective stage. So here we can see a paracentesis has been created and the anterior chamber is being manipulated so as to remove the collection of exudates. Now it's very important to do these surgeries under proper anesthesia, as topical anesthesia is never adequate and the constant blepharospasm and Bell's phenomena will pose problems in management, also makes the patient very uncomfortable. So here we have caught hold of the exudate after peeling it from the iris surface, and we are removing it from the anterior chamber, and this will be sent for culture sensitivity and gram stain smear. Now here we can see once the exudates have been removed, we can see the pupil which is very small, constricted, and there are synechia which are forcing the iris to be stuck on the lens surface. Because the foreign body was very small and was a flying projectile, we had suspected the patient may be having a retained lodged intraocular foreign body. So a CT scan and ultrasound has already been done. Once the prolapsed tissue has been reposited and freed from the wound, we have proceeded to repair the cornea using 10-0 nylon suture, and in these situations it is important to tie the knots judicially so as to not to cause too much of curvature change or astigmatism in the cornea. The first knot or the first suture is very crucial because this is going to hold against a lot of pressure, and it is possible that once the subsequent knots have been put up, this may appear a little loose. So one has to be ready for revising the knots and sutures as the surgery is proceeded. Now this incision, this laceration is very small, so just putting up 3 sutures will serve the purpose, and as we can see, the knots and the suture is being taken up so as to form a square if the subsequent and adjacent sutures are connected together. This is how a corneal repair should be done so as to have a formation of a hypothetical square if we connect the sutures. Now this is the final suture, and as we can see that this injury has had some time elapsed between the injury and the repair process, and there's a story behind this which I want to convey to the message to the public at large. This patient had presented to 4 ophthalmologists in the city, and none of the ophthalmologists was ready to take up the case for repair and management. Each one of them advised him topical medications and also suggested that once the infection is controlled, then they will take care of the repair, which is very counterintuitive because we all know that once there's an open wound, it is never going to take care of itself. And the reason for this is that the patient was very demanding, and in such a scenario, ophthalmologists thought that a poor prognosis case will land them into a trouble, in a sense that patient will be demanding outcome in terms of good vision and symptomless eye, which is not possible in such a scenario. So when the patients don't pay attention to the prognosis told by the doctor and have unrealistic expectation, this kind of situation is going to occur in future where the patients will be denied treatment just because the doctors want to protect themselves. This is the picture post-op day 1, where we can see intact suture and minimal hypopyon, and there is no extra exudate at the pupil. And this is the day 7 picture, where we can see the progression is good, but the pupil is still not being dilated in spite of being on mydriatics. Thank you.